Thank you. Hello, everyone. Welcome to Princess Steps Fall 2023, and this is week 6. Our topic tonight is heart health, and we have a very special guest speaker, Dr. Kevin Thompson, and he's going to talk about heart health. That's very, very important. He's spoken here in the past, and it's been very, very dramatic how many people actually have had their lives saved by the information that has been presented in here. And not just the participants, but their spouses as well. It's pretty amazing. And also, just as a reminder to those, some of you know, some of you don't, but several years ago, my mother passed away from heart disease, and it was hereditary. And she was extremely active all her life, doing farm work and that type of thing. So had she not been as active as she was, it probably would have got her before it did. So it's still to this day very, very inspirational to me to continue exercising, competition aside, because I know that that is hereditary in our family. Her mother also had passed. So here's Dr. Kevin Thompson. Come on up.
Well, thanks everyone. This is intimidating with this many people. So I think it's been about 6 or 7 years since I was here. Can everyone hear me okay? Okay, great. And I've known John and Susan for about 10 years. They've been so generous, and Susan's sort of passion for heart health and doing a lot of different races for the community and for heart health, Salem Hospital, cardiology, etc. So I've been a part of that a little bit, and it's been an honor, so thank you. We have about 30 minutes. We're definitely not going to go over. We might go under. Okay, let's make it very informal. I want to have lots of time for questions. I think that's usually the most value. Okay, I'm not going to get into sort of nutrition. You guys will have a talk, I think, later on that. And not going to get into too much exercise physiology, but more sort of general preventive cardiology stuff, and then wherever else it leads. So I'm an interventional cardiologist, so what that means is sort of I put stents in and heart attacks. So when I think of the heart, I think of sort of a house, and I'll explain, and I'm remodeling a house right now, so it's in the forefront of my mind. So plumbing is what I focus on. Sometimes we'll say I'm the plumber, and my partner's the electrician, and he's the one that deals with arrhythmias, so atrial fibrillation and palpitations that are so common. I put in stents and deal with heart attacks and sort of fixing atherosclerosis or hardening of the arteries more. But we all focus also in sort of general stuff as well. And the general house is sort of the walls, the pumps, okay, the valves, all the structure of the heart as well. Okay. But I think the biggest focus today is sort of how do we prevent getting cardiac disease in general. And when we say cardiac disease, most people think of what? I think we think of probably heart attacks, think of artery problems, right? But there's a lot more to it. When I think of it as kind of the whole house. But most people come in with just that focus of sort of the artery problems. So that's what we'll focus on, and how do we prevent that? And there's a lot of things we can do, and there's a lot of things we can't do. So genetics play a huge role, as Susan said, in terms of kind of the cards we're dealt, right? It affects our cholesterol, it affects our blood pressure, our risk of diabetes, all those things. So we control what we control, and we kind of improve the things we can. So cholesterol is a big focus of mine. And we can have people with very bad habits with reasonable cholesterol. And then there's other people that are vegan marathon runners that have super high cholesterol, and that's really not fair, right? But it's the truth, okay? So those people are limited what they can do from a lifestyle change, right? And that's when we sort of get into the pharmaceutical world. But there's plenty we can do in terms of diet and exercise. So sort of I applaud all of you guys for being out here. Running and exercise is a huge part of control of lipids, of blood pressure, and diabetes, 3 of the biggest things, okay? For me, I started running probably about 15 years ago. A lot of us, as we sort of as life goes on and we start to find a way to have structure, to me, running was the best way to make sure I did something. If I didn't have a race to do, that it was very hard to motivate to actually go out and do it. So running and biking to me are the things that I see in my patients and friends that allow you to kind of have that structure. In terms of cholesterol, there's a few things to talk about. You guys have probably all heard of statins, right? The evil of statins, I've heard it all, okay? I have more patients coming in that say they don't want to be on a statin than anything else, okay? Because of their friend down the street or their, neighbor and their family members. So I'll demystify that a little bit, okay? Statins are probably the most prescribed medications in the world in terms of groups, outside of pain medications, which are going down as everyone gets worried about giving too much pain medication. So the reason we hear so much about it is because they're prescribed so much, okay? And they have about a 10% side effects that are real. People have real aches and pains from statins, okay? And they go away when we stop the medication, okay? But that's about 10% of people. And it's probably the single most important thing of why we've reduced heart disease. About 25% reduction in heart attacks and strokes because of statins. So it's a huge value, and what we say to our patients is give it a try, and if you have a problem with it, fine, we switch it, okay? But to leave it off the table and not do it is sort of a big problem for a lot of our patients because of that fear, what we call risk aversion, when you don't want to do something because you're afraid of the side effect or afraid of the complication. The risk of not doing it is greater than the risk of doing it, right? So you have to kind of look at it. So there's many other medications too, outside of statins as well. Injectable cholesterol medications now as our technology is approved. Anyone ever heard of Repatha or any of these other injectable ones? There's one that's twice a year now, okay? That's more potent than a statin. Self-injected, sort of in the thigh, and they cause very dramatic reductions in cholesterol, okay? Once again, those are things after we've done our part, after we've done our nutritional changes and our exercise. From a nutrition standpoint, what we always recommend in cardiology is a Mediterranean-style diet, okay? I think the focus is really just less saturated fat, less red meat, probably. More fish, more good nuts like almonds and walnuts, okay? Good fats like avocado, okay? And, omegas like in our salmon, okay? Question about cholesterol. Anyone?
One thing I've heard is that the ratio of your HDL to LDL is one factor, because I have actually pretty high LDL, but I also have very high HDL.
Yeah. So I'm jealous of most of you in the room because most females have very high HDLs, okay? Not really sure why it's gender, but it is. And males typically have lower HDLs. We also call what's called metabolic syndrome, where HDL gets low, our triglycerides go up, and that's highly associated with sort of prediabetes, insulin resistance. We start getting abdominal obesity, increased waist circumference. So yes, we look at the ratio. We don't use it as much. We use purely the LDL as the greatest predictor. So that's the bad cholesterol. The HDL is the good cholesterol. We also have no target to improve HDL from the medication world. If a normal HDL is 50, say, and our cholesterol medicines may improve it by 5%, 2 or 3 point changes, not very dramatic in terms of how we impact it. Exercise does increase our HDL, and smoking decreases our HDL. So those are two things. We will look at the ratio after, but for the most part, it's the direct LDL.
My grandmother was a tiny woman. She was one of the ones that have high cholesterol no matter what she did. I'm lowering it and it's getting better, And so medication was kind of like, okay, let's just wait till next year and see where I'm at. But I can't seem to budget very much. Like, I've been like 25, 30 miles a week. I've been, it's just not.
It's frustrating.
Yeah, it's very frustrating. It is.
So when I had the discussion of when to start, we base it on a few different things. After people have tried different lifestyle changes, the reality is, unless your habits are really bad to start with, we only get about a 15% max improvement in our cholesterol, unless we're starting off really bad, okay? And the medications can do 50 to 60%, so that's why it's more dramatic. So we always want to, even if we're doing medication, supplement it with good habits, and those good habits don't just affect the heart. I mean, weight loss affects our joints and everything else, our diabetes risk, like there's a lot of different reasons to do these things. But it's depressing when you do all these things and it doesn't impact. One great way, which is a good segue in terms of when we start medication and what is our true risk. Patients come in and they have a strong family history and their cholesterol is borderline. Well, do they have the same genes as their mom, right? Did they inherit the same sort of risk? It's not always clear. So a coronary artery calcium score is something I use a lot. Has anyone heard of that? Okay. So it's a CT scan, a low radiation one, without contrast, just focusing on the heart. When we develop plaques in our arteries, we develop calcium. Nothing to do with our calcium metabolism, nothing to do with our dietary calcium, but the calcium goes to those little plaques in the blood vessel. So there's a way to quantify each little speck of calcium in your arteries. So if you have a 0 calcium score, that basically means you haven't developed really any plaque yet. Okay. So when we're thinking, what is our risk? Our cholesterol's been high and we get a 0 calcium score, or our brother unfortunately just died of a heart attack, do I have the same risk? And you get a 0 score, it just lightens that burden quite a bit, right? Conversely, if you're on the edge and you get a high risk score, then it tells us we've been developing a lot of plaque, your risk is a lot higher, we need to be much more aggressive with that therapy. So that's a good, when we have an intermediate risk or people that are sort of on the borderline, we use that to sort of guide when to start medication. Okay. Other questions about cholesterol, please?
Okay, so I know everybody's very different, so you can't just, there's not a blanket that you can throw over everybody. But if you were to have like high LDL and take statins for 6 months with a 50% chance of, or 50% fix on that, are you able to then wean yourself off of statins if you've then been making those lifestyle changes at the same time?
So, good question. There's no, if you stop a statin, there's no negative. Start there. So there are some medications that you have to wean off. Okay. For the most part, you could just stop a statin, and most medications you can. There are a few, and the pharmacist seems to want to scare every single person that you can't stop this medication. They have to call me, etc. Most of them you can, but you want to make sure of it. But there's no weaning. Okay. With a statin, you just go back to where you were. Okay,
Your LDL would jump back up.
Yeah. So even an example would be those non-statin ones we call the PCSK9 inhibitors, which are the injectable ones. Okay. In about 5 days, they'll plummet the cholesterol, LDL cholesterol, 100 points.
Oh, wow.
Okay. It's dramatic. Okay. You stop it, 3 days later, it'll go up 100 again.
Do you feel any different if that happens?
Not that I'm aware of, not that anyone's ever expressed to me. If you've made better habits, sure. But once again, it's modest, the improvement. So obviously you stop the statin, you're going to go up some. So people always get worried, am I going to be on medication for life? Right? And same thing with blood pressure medications. Well, blood pressure medication's a little bit different because if we really lost a lot of weight, better habits, sometimes our blood pressure, but for the most part, our body's declaring ourselves to a certain degree, and we just may need that going on for control. If you're right on the edge, sure, then you may not need it. but there's a good chance that you just need it to keep that risk under control.
I think there was another question over there.
Hi, if you're a reasonably healthy person, I'm not ever going to show up in your office, and I could have a huge score on that calcium score. So, what's a person to do? How do you figure out your risk if you seemingly don't have one, but it could be hiding away somewhere?
So you could do a couple things. Okay. Obviously, your primary doctor should have some focus on that and recognize when you have risk factors. Okay, and we'll see patients for preventive aspects if they're worried about multiple risk factors. Okay, in that patient. But you can do a couple things. Okay, you can. ACC is the American College of Cardiology. Okay, if you just put in ACC risk calculator, okay, it'll give you a little algorithm. A lot of what we do in medicine is plugging things into sort of cookbook algorithms. You just have to know where to look, right? But if you do that, you put your blood pressure, your age, your cholesterol in, and it'll give you a risk of what your risk is in the next 10 years of having a heart attack. Okay. And you guys would be surprised that usually it's pretty low. Okay. And you come in and it's 3%, and people go, oh, 3%, I'll take that. Okay. And they're not worried. As soon as they tell them that number, they're quite happy. We don't do calcium scores on people that are very low risk typically, because the chance is going to be smaller. Okay, we really only do it when that risk is creeping in the intermediate range, about 5% or more, or if we're having that decision about when do we start cholesterol. But our decision to start cholesterol medicines is also directly based on risk, because that gets factored into it. Okay, so if your risk is low, you probably don't need it unless you had a very strong family history, because the family history does not get incorporated into that very well. Once again, all these cookbook things we have to individualize as well, because not everyone's the same, right? So there are going to be situations with strong family histories, etc., where we may take extra caution for that. The calcium score, if you ever got to the point and said, you know what, I want to get one of those, you can go to OHSU or Salem Radiology, and they'll do it. Pay out of pocket $200. Okay. And they do it, and you get your score. Now, some of them want an order, some of them don't. You just have to talk with them. But if you wanted to, your primary could give it. But most of the times, you don't need an order. If it was abnormal, then you would, and you miss a call. But abnormal. Once again, we base it also on age and percentiles. So if a 75-year-old male has a calcium score, which we normally don't do, they're usually going to have some plaque in calcium at 75. So it'll also be based on their 50th percentile. The bigger concern is when you have a 40-year-old who's in the 95th percentile, and then okay, we need to be more aggressive with that. But it's one of those tests that is very, very reassuring. I've had many patients come in who are terrified of their family history, family members dying, and they had 0 calcium scores, and they couldn't exercise until they had information because they were afraid. Okay, and then I've had other people who are starting exercise, which Susan and John can attest to. Maybe they're not in good shape and they're starting to exercise, and you want to ease into things. Okay, but what is their risk as they start back? I mean, I've had previous marathon runners that 10 years later, they're trying to get back into it. They gain 30 pounds, and they're just a little bit short of breath. Well, they gain 30 pounds. Is it conditioning and they're 10 years older? But I've had those situations where they had high calcium scores, and then they had bypass surgery. There was more to it. So we tend to blame it on, I gain weight, and I don't do anything. That's why I'm short of breath and fatigued. But sometimes it's more to that. So that's sort of a good segue in terms of symptoms, okay? We hear that women specifically present differently in terms of symptoms, and that's true to a certain degree. With heart attacks and acute situations, those are more dramatic presentations. So whether it's a chest symptom or a back symptom, it's something that's very dramatic and severe, typically. Okay, but it is not always chest pain, and that's sort of the key. Okay, in fact, it's rarely chest pain. Pain we think of, we bang our arm on something, right, and it hurts. It's more of a pressure, a tightness, a band sensation, a heavy sensation. Might be between our shoulder blades, might be just in our shoulders, might go up our neck. Okay, those are more of the chest symptoms, but it can also just be significant shortness of breath. Okay, or significant fatigue. The key is it's with exertion. So if all of a sudden you walk to the mailbox, had no problem, and a month later, halfway there, you just can't get there, you have to stop. Every time you try to do the same activity, the same thing happens. There's no other explanation. Didn't just go to the hospital, have a pneumonia, just had knee surgery and you're deconditioned. You were doing that same level and now you can't. So it's an exertional sort of intolerance that all of a sudden you can't, and that's when we worry about the arteries. You're not getting the blood flow you need. Sort of, we think of it as sort of the pipe is constricted. You can't deliver the blood flow when the heart is working harder. If you get chest pain when you're sitting there and resting, but then you go and exercise and you feel fine, it is not your arteries. Okay? Very, very unlikely. Okay, there's some rare situations, but it's not an artery problem typically. It could be palpitations. Okay? Palpitations are sort of a general term that we use for sort of a perception or sensation that we feel the heart. The most common one is called a PVC, or premature beat. Okay? So that's sort of like this. We're going along. Boom. So we get a pause and then a big beat. And that big beat sort of, whoa, takes our breath away, may go up our neck, and it sort of takes us by surprise. We get a few of them in a row, and then we get lightheaded. That is the most common of these palpitations. And people can have one in a day, and they feel like they're going to die. Other people can have it every other beat and won't even know it. So the perception is so different in every person. There's no rhyme or reason of why we feel it more, some and some don't. Okay, we have about 120,000 heartbeats in a day, depending on where our resting heart rate is. So when we have one PVC, we're not too worried, right? We get worried if the heart is doing that a lot. A lot is about 25% of the time. So we're having 30,000 PVCs in a day. Okay. So I usually tell people the percentage, not the number, because if I tell them they have 1,000 PVCs, they get very worried. But then you tell them they have 1% and they're not too concerned. Okay. What other questions?
I just have a comment. I know sometimes Kevin and other people we've had unintentionally talk about running, and don't say walking. So I just want to reassure you and have him reassure all of you who are walkers, not runners, that that counts too for everything he said in reference to the importance of exercise. So just want to make sure that all you walkers aren't feeling left out.
Whatever the exercise is, and obviously we're in walking and running mode, but whatever an activity that gets our heart rate up, okay, and sustains it for that 20 minutes at a time minimum is great, right? So that's that moderate exercise that they tell us, 150 minutes a week, if we can do it. It's challenging to do, okay?
100, that's all.
Yeah.
Well, you guys are all doing more than that if you're doing your princess steps homework.
That's the Surgeon General states that. You know what percentage of our country does that? Whew.
It's very low. I can tell you that. It's very low.
30 minutes budget.
Yeah. So you had a question?
I did. So can you tell us a little bit about AFib, and is that something that runs in the family, or is it unique to the individual?
Yeah. So running, and I'm specifically saying running, not walking here, okay? Because running and biking actually increases AFib slightly. Okay, all endurance sports do, and they're not sure why. Maybe we get more dehydrated, more stress, more electrolyte problems. I'm not sure, but we see it more in athletes. Let's back up though. Atrial fibrillation, what is it? Right. So it's an irregular rhythm of the heart. Comes from one of our top chambers, the left atrium, which goes about 400 beats per minute. Okay. Our bottom chamber, the main pumping chamber that generates our pulse and heart rate, does not go at 400 beats per minute, thank God, right? So we have what's called an AV node, which goes from the top to the bottom, that regulates our heart rate. It's also the reason, as that slows over time, that our maximum heart rate slows over time. Okay. When AFib is going, our heart rate is very irregular and sporadic, okay? Because some of those signals get through, some don't. People feel the irregularity, okay? Because it's all over the place, and you go, whoa, what is going on? It's not a steady pulse and heart rate, okay? And it can go fast. It can go 200 beats per minute. The problem is it's going at, say 170 beats per minute when we're just sitting there. We're not running and exercising, right? So it's very disconcerting. Once again, some people don't even know they have it, a fair amount. And then some people, as soon as they go into atrial fibrillation, they feel horrible. Short of breath, fatigued, tired. The biggest thing is our exercise tolerance goes down. Because if you're going to go on your walk and you're starting at 160 beats per minute, you're going to tire pretty quickly. It feels like you've been on the treadmill already. So those people experience more exercise intolerance, but the symptoms vary, okay, a lot. The biggest thing we worry about with atrial fibrillation is strokes. It's highly associated with strokes, one of the most common reasons for a stroke. So depending on our other risk factors, okay, we sort of calculate where your stroke risk is, and that's when we use blood thinners. Okay, so we use blood thinners in that situation. There are likely genetic links to it. I don't know if that's ever been fully. It's not one of those, my mom had it, I'm going to get it. Okay, what we call the penetrance is not that high. Okay, it's not 100%, but there's definitely some genetic links to it. Caffeine and stimulants can provoke some of it. Caffeine really is not unhealthy for the heart, okay, but it can provoke more AFib. Alcohol, similar, can provoke some AFib. Moderate alcohol, besides calories, weight, and sugar concerns, if we have other issues, generally may be heart healthy, studies have shown, okay? But in excess, is when we get AFib, right? So AFib is usually like this perfect storm. So say it's Thanksgiving and you have some stress and anxiety seeing the family, okay? You have some alcohol that night, you get up, you're dehydrated, your electrolytes, and then you have a shot of espresso. AFib. So we call that holiday heart. It actually has a name. It happens all the time. So
you'd rather be at the Black Friday sale than at the hospital.
Did that answer most of your questions?
Going back to the calcium testing, so do they initially work it or look at your like a blood panel?
Don't need to.
You don't need to.
Yeah, it has nothing to do with your blood calcium levels.
Okay. It would be a
CT scan. Yeah, it's a low radiation one. It doesn't take very long.
Yeah.
No contrast.
Yeah. Okay.
Did you say you can ask for that?
I'm not sure if cell radiology is making people have an order or not right now. I know OHSU does not.
You know what?
OHSU does not. You can call them up and do it, and that's $99 at OHSU, but it's kind of far. Yeah. But you can call cell radiology. They might ask for a doctor's order for it.
Have you heard anything about, I mean, you've heard it. Anyway, this fish oil, is there any truth to it reducing cholesterol?
Yeah, there is, but it's a little bit confusing, right? So standard over-the-counter fish oil has never been proven to have a huge impact. There have been some studies on some high potent specific parts of fish oil that have shown reductions in heart attack. Okay. But those are specific elements of the fish oil and in a higher dose. Fish oil in general, we really use it for triglycerides. Okay. So some people think they're being all good and being heart healthy and they'll come in on triglyceride medication, fish oil, and actually can increase the LDL slightly. So it can have some counterproductive benefits, and it's not very potent overall. You know, what we usually encourage, unless our triglycerides are very high, just to incorporate that in our diet, in terms of our fish, things like that.
I have one question in regards to the triglyceride. Is sugar a contributing factor to that?
Sure is. Yeah, carbs are probably the biggest thing. I mean, we all know carbs are kind of evil, right? So carbs drive our diabetes risk. If we have diabetes or a high blood sugar, that drives the triglycerides high. And carbs in general will drive. So carbs, lack of activity, weight, thyroid problems, those are some of the things.
Thank you. Awesome. You can
Thank you.
go pick up
I
your
gotta
kids.
run. Gotta run to soccer practice.
I think next week is safe. That was so awesome. That was so awesome. I can always tell when there's a lot of questions. So I'm going to sign off on this. Thank you, everybody out there, for tuning in, and we'll see you next week.